going to narrow it down. Thank you. Hi, welcome. I'll talk about the transdiagnostic approaches. I'll go through 3 cases, Ahmet, Ayşe and Ali. They have different diagnoses. Ahmet has social phobia, and before going to work every day, he's anxious that he's going to make a fool of himself, and during the meetings he looks at his colleagues, whether there's any criticism, whether they're staring back at him, and when he sees such a sign, he is refraining from the eye contact. And Ayşe has a diagnosis of hypochondriasis, and most of the days she's anxious whether she has cancer or not, and she's checking whether she has any changes in her body or not. And when she sees a change and she goes to ER, there could be a simple redness, but she goes to the ER. And Ali, from the DSM point of view, has schizophrenia. He is anxious that somebody is going to hurt him, and when he goes outside, in order to understand whether people have such intentions, he looks at the faces of people, and when in order to evade an attack, he goes back home. Of course, all of these have different diagnosis, but they are coping with their problems in a similar way. Their actions about something and what they are anxious about can be different, and they're looking for a sign of danger, and when they perceive that there is a danger, they try to calm. And there are different disorders, but there could be, whether there might be the similar psychological processes, as saying. It's more biological, but I'll go through the psychological processes. Actually, we talked about this more, but there's disorder-focused approach. It focuses on the healthy controls of the individuals and how they can be distinctive from the other disorders. And there are some efforts to understand the etiological differences. And of course, this approach is used for understanding different disorders and developing the treatments. However, if there's high comorbidity and there are different treatment manuals for each disorder, and that's why there's a new approach for different psychiatric disorders. There could be some similar psychological processes, and in DSM it is not specific, but it is different. It points out. There are evidences showing that it might point out small variations, so there should be a more dimensional and functional classification. RDoC is an example of this.
What does transdiagnostic approach provide us with? There is a problem of comorbidity. There is a research conducted. A person with a mental disorder, for the rest of their life, he has the likelihood of 50% having a comorbidity of a mental disorder, and anxiety and depression, there is a comorbidity of 50%. How are we going to explain this high comorbidity? Does that mean that the diagnostic system's differentiation power is low, but we can say that their differentiation power is good enough, or one disorder might be a risk factor for the others? Insomnia, for example, the insomnia might predict the depression or the drug substance, or it might show us a specific tendency or anxiety disorder or neuroticism, and also low dealing capacity are the precursors of some other comorbidities. And so similar processes are out there. Therefore, we go with the transdiagnostic approach. So why is the comorbidity problem? Because when we look at that as a disorder, at least from the BTD, there are some treatment menus. It's different for the depression and it's different for the anxiety disorders. How are we going to start? Which one are we going to use? There are a couple of solution offers. The first one to diagnose is going to be treated the first. Or if one is the reason and the other one is the result, then we can start with the reason, but it's not that easy. Or we can start treating the disease of which symptoms are more dominant, and we are trying to define these criteria according to the data given by the patient. And we need to be looking at the basic processes, and this can help overcoming the comorbidity problem. And apart from that, another advantage of this approach is it's making it easier to generalize the information, and there might be some other developments or for treatment. And it's a different, there might be some other approach, and it might be applicable for other disorders, and this data can be transferred in a faster fashion. Another treatment component, there are treatment components which might be efficient for many orders, like the attention education, or the self-training therapies, or acceptance and decisiveness therapy, or the compound protocols for the emotional disorders. Therefore, it has been shown that it's efficient for many disorders. And the third advantage is that in the disorder-based approach, once a disorder is treated, in the comorbidity diseases, there is an amelioration. You're treating the depression, but the symptoms of the anxiety also get better. This is an effect without knowing. Transdiagnostic treatment approach lets us get better answer about this comorbidity. Apart from that, the disadvantages, the training burden of the therapists can be alleviated. Again, for the diagnostic, the person can spend in aiming at the basic processes time-wise. Again, it can prevent stigma and the problems of the systems. And when we focus on the disorder, sometimes we have a tendency to avoid the person, so it might contribute to personalize the treatment. Transdiagnostic approach, is it brand new? When we look at that, at the beginning of the 20th century, psychoanalytic approach was not a disorder-based approach. It's talking about basic psychological conflicts, and in the interventions are transdiagnostic interventions, whatever the disorder is. it's all about discovering the self-characteristics of the person, and it's trying to put an end to the conflicts, personality conflicts, and it's increasing the emotional expression and also the discussion of the previous lives. And behavioral approaches in the early period, both the etiology and the other one, it might be classical conditioning, transdiagnostic, or the exposure during the treatment. All of them can be transdiagnostically. Back then it wasn't defined like that. We are talking about transdiagnostic process. How have we defined it? How can we classify it? There are many researches in that regard. A process is being defined, but there is no certain classification. We're here talking about the psychological, biological, social and emotional. The amygdala, for example, has many relations with many disorders, or serotonergic system. It has relation with the depression or eating disorders or schizophrenia. We can differentiate it like this, and there are some predisposing factors. Again, the genetic structure of the person, the beginning of the disease and the trend of the disease, or precipitating factors. A life event, for example, in the acute period, the effect is high, but as you can see in the graphic, the factors might change. And these factors, continuing factors, the continuing factors of the disorder are the ones which have been researched the most. And transdiagnostic can be divided into two categories. One is the definitive and the other one is the mechanic. And if we talk about the definitive perspective, a structure, no matter how and why, it shows us that there are many disorders. And so there isn't a causative effect. And from the mechanical part, when we say transdiagnostic, and this is related to a series of psychopathology like the rumination or anxiety, these processes, psychopathology, continue. I don't want to go into detail, but the most important then. In 1999, Ingram defined such a process, self-absorption process. This is about him or herself, the opinions about herself. This is about the internal attention and the differentiation factor of the disease is the content of the opinion, and meta-structural model, critical psychopathologic characteristics and common psychopathologic characteristics. This makes a difference. And these are the first examples of that. And also suppression of the opinion, depression, PTSD, and obsessive compulsive disorder, OCD. And after just diagnostically processed in the social phobia, for example, the opinion suppression process is not that effective. And also about the eating disorders, there is a modeling. model link system by Fairborn, and there is a special protocol about that. Bulimia nervosa, anorexia nervosa, and atypical eating disorders are coming from the same root. The eating habits, the physical appearance, and also the weight, that person is always judging himself in terms of these three parts. And the physical appearance and the weight is overrated, and these symptoms might be related to them. And the person is obsessed with them. There might be some limit on the diet, or he's acting with eating limiting behaviors. So, or he might overeat, and as a compensator, laxative or diuretic can be used by that person. And this is equally effective with the BTT. The efficiency is 50%, therefore additional processes need to be defined. The perfectionism, low self-esteem, and the emotional situation intolerance, and also other interpersonal difficulties, and a treatment is developed accordingly. And these are the first examples of developing a transdiagnostic protocol. In 2004, Harvey et al. Made a very expanded research. The transdiagnostic process is being defined, and this is an effective process in all the disorders. This needs to be defined at least at 4 diseases, and they defined 12 processes under 5 titles. You can see here, cognitive and behavioral processes are the 2 main items, and their processes about the attention, again about the memory and reasoning processes. Again, thinking processes, the repetitive thinking processes, rumination and anxiety, are defined as transdiagnostic processes, and as the behavioral processes, the avoidance and the security providing behavior, and life avoidance. There are many proof supports, and it's added to the latest table, and Şengül is going to be talking about this avoidance. Another study was conducted by Barlow. He's talking about neuroticism, and he's defining neuroticism as follows: frequent and intensive negative emotions, and that person has no control over these emotions, and rather than the negative emotions, the reaction towards the emotions are pathological, and interventions have to be made through them. And there are three tendency approach: the general biological tendency, the genetic processes or the life events. Neuronal stability can be affected by the life events, not only the genetics, but also the process afterwards is also effective. And in the psychological tendency, the person has the perception that he or she cannot control them, and there are some structures, hypothalamus, thalamus, etc. And it gives a ruined stress response, and it results in neuroticism, and it is handled as a transdiagnostic process. And in all emotional disorders, are effective. And when we say emotional disorder, we mean anxiety disorders and depression. Which one is defining which? Psychological tendency. And the learning story can be effective in that regard. And in the anxiety disorder, neuroticism is the phenotypic equivalence, and according to the learning story, it might be either OCD or PTCB. Some other anxiety disorders might arise. Barlow's research is important because he developed a protocol about the transdiagnostic treatment of the emotional disorders. It's called as the Unified Protocol. It's about the reactions to negative feelings of oneself, and psycho-training is included, emotional feelings about the moments, and the cognitive evaluation systems are being managed, and also the behaviors are being learned, and strategies are being used in that regard. Apart from that, there are many other processes defined, like the sensitivity to anxiety, and increased responsibility, distress intolerance. The anxiety sensitivity was related to the panic disorder, but then it was discovered that it is also related to some other anxiety disorders as well. Different results are coming out from new studies. Yes, we are making definitions. We are saying that there are many similarities about the disorders. So what makes these diseases different? This is the ultimate question. There are some hypotheses in that regard. Current concerns, unique to mental disorder, the stimulant, which will be remembered, it is defining the behavior to avoid the danger. If it is OCD, then the concern is about the contamination, and the behaviors are in that parallel as well. And it is the same thing with the eating disorder, the weight, the physical appearance, and the same cognitive and the behavioral processes are out there in both of them, but the clinical appearance is different. In OCD, selective attention, or sensitivity to the contaminant and avoidance, etc.
However, in eating disorder, the clinical appearance is different. So, yes, they are different, but why are they different? This is a second question following. It could be biology, personality, learning, history, traumatic events. For example, in the studies, there could be, if there's a dental anxiety, there are some adverse dental experiences in sociophobic individuals. The parents are less sociable, and in PTSD, it is related to trauma, as we know. Another explanation is about the basic processes balance. They could be seen in different levels in different disorders, and this could be explained through different clinical presentations. The internal consciousness is examined, and it's highest in social phobia, in OCD, in panic disorder, in bulimia nervosa. It's normal, so this could be a balancer. And another explanation is regarding the common processes, and it could be a specific process, and it could explain different clinical presentations. For example, in psychotic results, there is a tendency to jump into conclusions, and also there is a tendency to refer to outside conditions. So this is something new, actually, regarding the future, and there is an increasing interest in transdiagnostic approach with our dog. So what will happen in the future? What is the plan? These processes are defined, but the relations among the processes are not clear, and some processes can measure the common thing, not distinctive things. And there could be research regarding this, and it should be some comparative studies. There should be some comparative studies to see whether there's a superiority to disorder-focused approach, and there's a need for mediator research as well. This is a brand new, and we will see what will happen in the future together. Thank you very much.